general aspect of fracture. And the second part is a case presentation. And today also our mentor is Dr. Anita, and she's already here. So I think we can start our presentation now. So Lily, you can go. Yeah.
Okay, thank you very much. I'll share the screen. Oops. Can you all see? Okay, then let's start. So I'll first be talking a bit about the diagnosis of fractures. So what are we going to do? We're first going to look at what a fracture is. Then we're going to diagnose, and then we're going to look at how the diagnosis process looks or what it looks like. Then what types of fractures there are, some complications, some pathology. We're going to go back to fractures, but this time in radiographs. I'm going to summarize everything, and then there will just be sources. So, whoops, why can't I? There we go. What is a fracture? To put simply, a fracture refers to a broken bone. So this. The procedure with fractures will usually look like this. So a patient will first report with symptoms, either in clinic or somewhere else. Then a history and physical examination will be taken. We will proceed with medical imaging, so usually X-rays, but also CT scans or MRIs. And from that information, we can then suggest some treatment, so surgery, for example. But we're going to look at the diagnosis in radiology. And for the radiograph examination, there's 4 steps about. So we're first going to look at demographics, then the location of the fracture, the type of the fracture, and lastly, the displacement. So first about the demographics. That basically means we'll be checking the radiograph. Is the data correct? Is that the correct patient? So correct patient name. Is it the correct body part inside? For example, if a patient were to break his right leg, but then we suddenly have an X-ray of the left leg, that would not be very useful. Then we also have to look if the radiograph is up to date. So look at the date, and then also the location of the procedure. So if it's on the hospital name, eventually also the patient room number. For location of the fracture, we're going to look at the bones that are injured. So which bone is injured, which part of the bone is injured. So epiphysis, physis, metaphysis, or diaphysis, or you can also just use proximal, medial, and distal. Then we're next going to look at the structures that are fractured. So are any tubercles injured or anything special? And what specific features of the fracture are there? So is a joint, for example, also involved? Then for the types of fractures, there's a lot of types. There's so many. I don't think I could fit them all in this presentation. So I just summarized, or I just wanted to show you the most important ones. So the ones you will probably use most are complete and incomplete fractures, but I will also be mentioning infraction, stress fracture, pathological fracture, and avulsion fracture. But like I said, the most important ones are complete and incomplete fracture. So a complete fracture refers to the complete breaking of a bone. Pretty logical. So on a radiograph, that would be more straightforward. As you can literally see a line, so the bone is just broken full through. There will probably be more angles required to assess the whole fracture properly, because there will be some three-dimensional movement, or maybe you won't be able to see the fracture properly from only one angle. But there's also several different types of complete fractures. There's, for example, the transverse fracture, oblique, spiral, longitudinal, segmental, and commutative. The transverse fracture refers to a fracture straight along the bone, so just like this, as you can see on the X-ray here very well from the patella, so just straight along. The oblique fracture refers to a slanted fracture, as you can see here. Then the spiral fracture is a twisting fracture that kind of goes like a corkscrew. The longitudinal fracture is longitudinally on the bone. It's a bit rough to see on this X-ray, but I think you can make it out. The segmental fracture refers to a bone that is broken into segments. The comminuted fracture refers to a fracture in which the bone breaks into 3 or more pieces. This is very common in accidents or also, for example, shootings, where everything is just, splinted. Let's move on to incomplete fracture. So what is that? That is the non-complete breaking of the bone, as you would have probably guessed. And they're most common in pediatric patients because they have a higher bone elasticity. So we're going to talk about 3 main ones. So bowing, torus, and green stick fractures. The bowing fracture is a plastic deformation or bending of the bone, as you can see here. That's pretty crazy. It mostly occurs in the antebrachium, and like I already said, almost exclusively in children. The torus or buccal fracture has no distinct fracture lines, which makes it a bit more difficult to make out on the radiograph. But you can see here that a buccal kind of forms, so that there will be some kind of compression going on there. So there's a very weird element forming, which will usually also cause some very weird angulation of the bone. And the green stick fracture is kind of halfway between the complete fracture and the incomplete fracture, as the bone bends and cracks, but doesn't really break completely. So you can see that here very well. Then let's move on to other fractures that are worth mentioning. So we're going to look at the infraction, stress fracture, and Divulging fracture. Oh, wait, is this? There we go. Infraction is the incomplete fragment fracture without displacement. There's also several types. The most common one you will hear is the Freiberg's infraction. It usually originates from osteochondrosis, which is a bone growth disorder, and it often occurs on the head of the metatarsal bones. You can see it a bit here, like there's some fragmentation going on. And on the radiograph, you'll be able to see flattening and widening of the bone, and also fragments forming. What is quite interesting with this kind of fractures is that you would be able to see kind of progress through the different radiographs in time. As it is a disease, or disorder, it will progress. So this will change over time. There's 2 types of stress fracture. There's fatigue fracture, in which excessive stress is placed upon a normal bone. And there's insufficiency fracture, in which normal stress is on an abnormal bone. And it is most common in the lower limb and can be quite difficult to see on the radiograph due to the small tears it causes. Avulsion fracture, it refers to a fracture in which a ligament or muscle pulls off some bone and then thus causes the damage, as you can maybe see here. Let's move on and talk about complications with fractures. Until now, we've talked about simple fracture, in which the bone is only fractured and everything is still internal. There's also something called compound fracture or open fracture, in which dislocation is paired with a soft tissue injury of the dislocation of the fracture is paired with a soft tissue injury. So the fractured bone or dislocated joint is in contact with the outside, as you can see quite well on this X-ray. For complications, there's also joint involvement we have to think about. So how will the joint be affected? What changes are there in the intercapsular, articular way, or is there some kind of dislocation going on? As you can see, this joint will not work properly. This is a so-called boxer fracture of the metatarsal bones. Let's talk about pathology. So there's something called a pathological fracture, in which the breaking of the bone is caused by a disease, not an injury. We've already talked about one of those. It's, for example, the Freiberg's infraction. But also, when we're talking about pathology, there's a pathophysiological response of the body to the fractures. So at first, there will be some inflammatory responses. So a hematoma will be forming, which stops the bleeding, which will also cause more inflammatory which also cause more inflammatory cells, and it will also form a callus of some sorts. Then it will be reparative, so the primary callus will be replaced bit by bit by a bony callus, which will cause more stabilization in the fracture. And then last, after a couple of weeks, there will be remodeling, formation of the cortical bone. Actually, this will take longer than weeks. This may take months or even years. Finally, let's go back to our diagnosis of the X-rays. Let's talk about displacement. Usually when talking about displacements, we're talking about the proximal fragment and the distal fragment. And there's also different kinds of displacement. For example, fracture dislocation, in which we will write down the amount from length to width, of length or width. For fracture angulation, we will measure the amount, there we go, in degrees as well. Fracture rotation also in degrees. Fracture impaction, we will paraphrase a bit, but there we will look at the ends of the bone impacting together and whether that causes some shortening. And the fracture length will also refer to distraction, impaction, or shortening. So fractures and radiographs. Usually X-rays are sufficient to analyze fractures, in which different angles or positions will be necessary to get a complete picture of the fracture. But other imaging methods may be useful when complex anatomy is affected, when films are insensitive to the fracture, or if it's a pathological fracture. So let's summarize this whole chunk of information we have just discussed. So when it comes to the diagnosis of fractures with radiographs or imaging, we'll first look at the demographics. Do we have the right patient? Do we have the right body site? Then we're going to look at the location of the fracture. Which bone is it? What structures are affected? Then we're going to look at the type of the fracture, mostly complete, incomplete fracture. What kind of fracture is it? And then lastly, we're going to look at the displacement of the fracture. How did the bones move? And then thank you very much for listening. Do you have any questions? Or additions?
Hello, this is Anata speaking. Thank you for a presentation. It was very nice. I can comment nothing bad, only good things. And just one short comment that it was very good point to make that about those demographics that you always have to check the patient's name and personal data to be sure if you see the same patient's radiograph of which, for example, your attending surgeon is asking or is interested in. So yeah, that is very important. I agree. And of course, about the fractures, as you have heard, there are this AO maybe classification, and there are many type of fractures depending on which kind of joint we are talking about, and I guess you will catch it up in the time of work. For example, then you open this atlas and then you check, okay, this is this and this is that. So yeah, but yeah, that's it from me. Thank you.
So if and nobody has questions, then we can move to the second part, which is the case presentation.
Yes, so I'll be doing that. Just 1 second. Do you see my screen? Yeah, okay. So we'll start with the surgical case. So an 18-year-old male was admitted to the emergency department after a high-speed car crash. The patient is unconscious and the neck and pelvis are immobilized. Physical examination shows hemodynamic instability, an open wound over the right leg, multiple lacerations and bruises around the body. The emergency team are attempting to stabilize the patient. So you have the information, and as orthopedic surgeons, what would you like to do? What kind of physical examinations would you like to do further? So this is a question for all of you. And I'll be waiting for the answer.
Well, we should ensure that the breathing is stable, that there's enough oxygen flowing, that there's no bleeding, and in case of bleeding, we have to stop it. So the general ABC, DE steps.
Yeah, of course. So mainly the orthopedic surgeons, they won't be doing that job. So it's mainly the emergency team that will be like handling, doing the ABCs. And meanwhile, you'll be checking out other stuff. So what is this other stuff can you think of that you could be doing?
I'm sorry, could you maybe go back to the prior slide?
Yeah.
Thank you.
So does anyone have something else to say? Like, no, okay. So basically the orthopedic surgeon, they usually check for the fractures. They basically hold the extremities and they move them kind of like this to see if there's a fracture. And they would be doing this for the extremities. And if you're a senior surgeon, you can do the pelvis as well, but if you're a young surgeon, probably you shouldn't. But yeah, so you also check, as you said, for neurovascular integrity. You check if the patient is feeling, obviously if he's unconscious, you can't do that, but something to keep in mind. So what you would find after you do this, you would find a right mid-shaft femur open fracture. And so you found this, what do you do next? So what are you interested in?
Well,
probably we will do imaging. So we want to know what kind of fracture it is, how severe.
Mm-hmm. Exactly. So you would do diagnostic testing with X-ray, probably CT. And so you do your X-ray and this is what you find. So here's a frontal view of the right leg. And you can see that. And then I'm gonna show you more pictures. So here's a lateral view. And then here's a special lateral view of the hip. Okay, so do you guys want to see it a bit longer? Should I go back? Maybe a bit. You can see here is a good picture. Yeah, so what do you see? Like, can someone tell me what they see basically? What kind of fracture is it? The expert will speak herself. Yes.
So that would be a segmental fracture and a compound fracture as well.
Yes.
So, and I suppose you would first go about in trying to align the bone again with the fracture.
Yeah, we will get to that soon. So I'll show you the CT as well because it's very interesting. I don't know if how I can share that. Here. So yeah. So here's the CT. This is the axial bone view. And we'll start from the knee level. Yeah. So that was one, the coronal view. And then you have the sagittal view. And the 3D constructed. And here's important as well. This is the arterial phase, which is when they put contrast and you see if the arteries are intact to see if the blood vessels are good to go, something's injured or not. Yeah. So maybe it's really like a bit difficult. I don't know how much you know about CTs, but yeah. Like, do you guys see some findings that you'd be like, oh my God, something new, just other than the fracture? Maybe someone can comment.
I don't know, it was a bit fast. I don't know if there was a hemorrhage or not, if a blood vessel was damaged. I couldn't tell.
Yeah, it's really hard to say. But there was a hematoma in the anterior compartment. I'm not quite sure exactly where it is. But the arteries were they were okay in general. And then they could also see subcutaneous air, those like bubbly, like this bubbly small stuff is air, and it's an evidence of an open fracture. Also, there is another fracture at the knee level of the other leg. So I'm going, okay, we have to go down. At the patella, so here, there's another fracture. Here you see the patella, and on the lateral condyle, the lateral or the, yeah. So basically that's it.
I can comment that sometimes hematoma is better seen on native scans, not with contours, because hematoma is usually hyperdense, as is there is blood. It's higher. Maybe we can check it one more time.
Is it this?
Maybe
I think it's this whole thing, right?
Yeah, I guess where there's also these air bubbles inside, it's a mix of everything. So most likely it's there. Yeah.
Yeah. Okay. Yeah, that's it for that one. So let me share the presentation. Okay. So the findings was what I said, basically. I think it's enough there. The treatment options for this case, basically, first you start with surgical decontamination and then a temporary external fixation. Because of the extensive soft tissue injury, the patient is not suitable for the surgery, for a definitive surgery. And also he could be, because he's unstable. And the definitive therapy is the intramedullary nailing. And this is when there's less extensive soft tissue injury and when the patient is stable. So the preoperative preparation, of course, you need the site and the site of the fracture. You have to have the type of operation planned. You need to ensure that the operative site is marked so you don't get the wrong leg. And you need to see the condition of the soft tissues. They're so important. The implant type, the patient positioning, the details of the patient, gotta get that consent, the antibiotics in there, the thromboprophylaxis, everything. See the comorbidities, allergies. And then with all that information, you see either he's fit, they're fit for the general or the regional anesthesia. So if a spinal anesthesia is used, make sure that the procedure is not longer than 1.5 hours long. And you have to also avoid long operative pain blocks, because then it can prevent from seeing other complications like compartment syndrome. So the treatment, as said, external fixation, the main indication is the soft tissue damage in the patient being unstable. And the definitive would be the antegrade intramedullary nailing. So for antegrade nailing, the indications is that the main indications is for closed isolated fractures, mostly open fractures and stable polytrauma, and all patients with femoral shaft fractures except those that are not fit for the definitive surgery. Closed fractures, Gastulio type 1 and 2 open and clean 3A fractures, and then polytrauma patients in stable condition. Contraindications is polytrauma patients with unstable condition, and if the intramedullary canal is occluded, and Gastulio type 3B and C open fractures. And this is the summary for the Gastulio fractures, and the contraindication is basically these two: when they have, the bone is exposed to air, basically. So for surgical procedure, I'm mostly gonna focus on the segmental fragmentary middle 1/3 femur fractures. So the first step is to determine the nail length and the diameter. And since it's a multifragmentary or an open fracture, it's hard to see the length of the femur. So you take the uninjured leg and you take all the measurements from there. And this is how it's done. This is a radiologic ruler. So you can see this ruler through the image intensifier, which is the X-ray you use. So you put it on the femur, and the correct size would be this: the center of the number would touch the cortex of the femur. That's the diameter, and this is how it looks like in real life. And then for the length, you would go from start to end of the bone, and that's basically how it looks like. So this is the image intensifier, aka X-ray. So after you've done that, you've taken the nail size, everything's ready. You position the patient, and I chose the supine knee flex 30 degrees because it's really good for AP and lateral imaging for this procedure. Then you disinfect the skin and you drape this patient. Now we have a sterile field. You have your surgeon here, your surgical assistant, your nurse giving you the tools, the anesthesiologist, the image intensifier, and where you have the images popping up. And then you have certain approaches. You can go with a piriformis entry point if you're using a straight nail. You can use the trochanteric entry point with proximally curved nails. We're going to use the trochanteric entry point. And yeah, basically that's when you incise the skin and you enter from the tip of the great trochanter. And yeah, then you can, when you reduce the fracture, you have a lot of ways of doing it. And it depends, like surgeons have different ways. So you can either elevate the distal fragment by using a crutch. You can lower the proximal fragment by external pressure with a mallet. You can wrap around the femur. You can just use a shank screw. You can use a bone hook. You can do it manually, and so on. You can use during insertion of the nail, you can use the nail, like someone can press from the outside, millions of ways, depends on the surgeon. So in this particular procedure, we're gonna rim the intramedullary canal, and this is for smooth nail insertion. And you have to use the protective tissue sleeve, very important. And you start with a 9mm drill bit, this little thing here, and you increase by 0.5 increments. And this you do until you have about 2mm bigger hole than the nail size. And you do this until the end of the femur if you can. However, if it's multi-fragmentary, you can do only the proximal part so that we don't compromise the vascular integrity of the femur. Mistakes during reaming. So you can be eccentric reaming when you go in the wrong direction. You can have the reamer gets trapped because you're going too slow. And then a senior surgeon has to come and help you out there because it's really dangerous, like complications. Then you can have heat necrosis by over-aggressively reaming. And also rapid thrusting, like with motions, can cause fat immobilization because you're just letting the fat come out pretty quickly from the canal. It's not cool. So then once all that is ready, you can insert your nail. You use this insertion handle and you connect it to the nail by a screw, and you screw drive that thing. Then you use a driving cap, like when you, so you basically start inserting the nail into the femur as much as you can. And then until you reach a certain point, you can use this driving cap and then use a hammer and hammer the nail in, so to help you out. And basically when you've put in the whole nail, it's reduced now, the fracture is reduced. You use this K-wire, which is this K-wire, and you put it into the insertion handle and you check in the image intensifier if the nail is positioned correctly, because now we have to fix the nail. Like, we're not just going to put it in and leave it there. So now we do the nail locking. It was when we distally put in screws to lock the whole nail. And we position the intensifier laterally, and the scalpel tip has to be in the center of the hole that you'll drill in. You make an incision in the skin, like so, and then you position the drill tip in the center, again to double check. Then you drill the hole, and then you use the depth gauge to measure the screw length, which is this, and then you insert the nail with a screwdriver, like so. So here's the image of when you put the nails. One is correct length and one is incorrect. The proximal screw is correct and the distal is too short. And this too short screw is not good because it can loosen up when the patient starts moving. So we have to get a little bit out of the cortex for the correct position. Then we do the proximal locking, and you use this device to do that. So you make an incision here, right here, and you put this drill sleeve, always protect the soft tissues. And then you either use a drill that has a calibrated drill bit to see the screw length, or you use the depth gauge. And then you insert the screw with a screwdriver. And this is how it looks. And then you have to confirm the screw length with an AP view image. So this looks good in general. And then you remove the insertion handle, and then you can insert, so it depends on the surgeon, you can insert this end cap, which can protect from soft tissue growing inside the nail, so that when you extract this nail, you can use the extractor device, can immediately just go into the extraction site so that you can remove it pretty nicely. So there are two ways of doing it. You can do it conventionally with using a hexagonal screwdriver, or in a non-conventional way when you insert the end cap with a guide wire and a hook so that you don't lose the end cap. And then you tighten it with a 11-meter wrench. And then that's it. You close up the patient, you suture the fascia and then the skin, and then you assess the rotation and you compare it to the other leg. You could also perform an extensive examination of the joints and see what's up if there are other injuries. So now that we're done with the surgery, we have 3 phases of post-operative management. So the first one is immediately after the surgery, we need to do pain control, mobilize, prevent, and recognize complications. And then the second phase is after the hospital, when the patient is integrated into the social environment and is mobilized. And the third phase is when you conclude the treatment. Basically, you see the result of your treatment and the patient returns to their activities before the surgery. The first phase is pain control. We do this according to the WHO analgesic ladder. You can see it. I'm not going to go into detail. Then you have to do wound care. You elevate and support the injured leg. So you position it at the level of the heart to minimize the swelling, as well as having good perfusion. And you manage prophylaxis, swelling, mobilization. And for prophylaxis, for thrombosis prophylaxis, early mobilization is very helpful. And for the lower limbs, usually you cannot weight bear on your legs immediately because of the soft tissue swelling. So you need to make sure that that's gone down and the wound shows no signs of inflammation before you can do that. Then you have the physical therapist coming along, helping out. They show you static quadriceps exercises with passive range of motion. And this is usually on day 1 if there are no complications or injuries. And here are some other things. I'm not going to go into detail. Then for weight bearing, there's partial weight bearing at 15 kilos for 3 weeks or 4 weeks. And then you can have full weight bearing, basically. Then, of course, the post-operative control X-ray documents to document the fracture fixation, the orientation of the implants, and this will be the basis for evaluation how the fracture's healing process is going. The follow-up, wound healing should be assessed regularly within the first 2 weeks. Then 6, 12, 8 weeks, clinical and radiological follow-up is usually made. And then a longer period may be required if the fracture's healing is delayed. For complications, compartment syndrome, very important to monitor the first 48 hours. Infection, especially with open fractures, so the injury to the nerves and blood vessels, thrombosis, thromboembolism, fat immobilization, embolism, oh my God, male alignment, male union, basically same thing, delayed union or non-union, when it heals slower than usual or not at all. And then you have hardwire irritation. So sometimes the screw or the end of the nail can irritate the muscles and the tendons. And for prognosis, the patients who survive the initial trauma associated with typical injury typically heal well. Early immobilization following intramedullary nailing greatly reduces complications. Bilateral femur fractures have higher rates of pulmonary complications and increased mortality rates compared to unilateral fractures. And patients over 60 years old have a mortality rate of 17% and overall complication rate of 54%. And that's it. Sorry, I talked so much.
I have one question. So it was a segmented fracture in the case, and visually, I don't really understand how we can fix it with a gamma nail. So, because I saw at least some 5 fragments, were they all just screwed into the nail then, or?
Yeah, let me just go to the pictures. Oi. Let me just share it again. You mean this one, right?
Yeah, exactly. Oh, that was fixed with the gamma nail, right?
With the
Oh,
what?
with the intramedullary.
Yeah, this was first this was fixed with external fixator. And basically with that, you can kind of reduce the fracture. So it's kind of straight, and you do have the fragments, like they're just there. And that's how it is until you put the nail, and
Okay.
sometimes the fragments will heal together, but sometimes the surgeons will go in there and they will put K-wires, and depending how far away the fragment is, sometimes the bone fracture is not even viable. It's dead bone and they just keep it there.
But
So
in
it
this
all
case, it was external fixator and then intramedullary
Yeah.
nail.
Yes.
Okay, thank you.
Yeah. So any more questions?
Yes, in the beginning you said the surgeon is moving the joints to check if there's a fracture or not, but isn't it dangerous and you can even increase a fracture if you're just rapidly moving the joints?
Yeah, so this is a skilled surgeon that would slowly move the legs and stuff like that. And yeah, you can do injury, but he's already injured. So that's what I saw from my placement. That's what the surgeons did basically.
Okay, I think we have also 2 questions in the commentary section.
Okay. Wait, I can't even need to get there somehow. Yeah, I can see it now. Okay, so why is it not treated with a plate? So for this case, it's very, it's a huge fracture, and with plates, it's not sufficient to stabilize the fragments or the whole bone. It's a big bone and it carries a lot of the weight. So it needs something really strong to be able to stabilize this fracture. And a plate is not strong enough to fix the bone and keep it in place. I'm sure that if the patient starts walking and you put a plate, it's just gonna come off. It's not sufficient enough, basically. So what is compartment syndrome? Compartment syndrome is when basically the pressure, the soft tissues are swelling up so much. So there is fascia between muscles, and if the soft tissue is injured and it starts to have inflammation and there is major swelling, the fascia is basically, it's very tough. It's not elastic. So the fascia will, you will compress the nerves, the blood vessels, and it can cause tissue necrosis, and it's not acute complication. So if that happens, you have to actually you have to do a fasciotomy, which is cutting the fascia to release that pressure from the swelling, so that to stop further injury to the soft tissue, if that made sense. Yeah. So are there any more questions? Has anyone seen an orthopedic surgery before? Yeah, that's cool.
Though it was not something as crazy. It was a hip replacement, and like I've seen a couple of hip and knee replacements.
Okay.
But it was actually quite interesting because they also had the same measuring tool for some screws, and I didn't know that it worked like that. The one you showed with the dots. Like I just saw that they somehow measured something, but I think that was them.
Yeah. I've seen some hip replacements as well. It freaked me out a bit. Like the fat tissue really freaked me out. Not the actual procedure. Yeah.
Yeah, it's quite cool.
Yeah, it is pretty cool. I'm gonna stop sharing, I guess. There we go. I guess that's it for me then, if there are no questions.
And does Dr. Anita have any comments?
We can't hear you.
As I'm radiologist, I don't have any comments about surgery, but thank you for your presentation. And as you presented to us, that also a surgeon, orthopedic surgeon, needs to know radiology, and sometimes surgeons know better and understands better the alignment of the bones because they see it in the surgery and then they see it on the screen and then they can put it better together. And that's why we usually work in a team. Yeah, and that's why surgeon is always consulting radiologists and vice versa. Yes. And for me, I have seen maybe orthopedic surgery, I don't know, before 10 years now. Lying, I don't know, never. It was a long time ago. So yeah, but thank you for your presentation. No comments from me so far.
And in the chat, we sent the feedback form, so you can fill it up. And also for Radiology Society, we're still looking for the presenter in May. The topics about PET, CT, and scintigraphy. And if you are interested, you can go to our Facebook page and fill up the form. And yeah, so if no one has question, then yeah, we can end the meeting. And thank you, Dr. Anita, for your time. We really appreciate it.